to the conference session titled MDS to AML. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation using the Q&A icon in the engagement panel on your right. To submit a question or comment, type in your question or comment in the Q&A text box window. When you have finished typing, hit enter. We'll do our best to get to everyone's questions today. When asking questions, I do ask that you do two things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. Our specialist today is Amer Zeidan. Dr. Zeidan is an associate professor of medicine, hematology at Yale University. He is also the medical director of hematology early therapeutics research, the leader of the myeloid malignancies disease aligned research team, and the director of the continuing medical education at the hematology division at Yale Cancer Center. Dr. Zeidan completed a hematology oncology fellowship and a clinical research fellowship in myelodysplastic syndromes at Johns Hopkins University, where he also earned a Master of Health Science degree in clinical investigation. Dr. Zeidan specializes in the management of myeloid malignancies, especially MDS and acute myeloid leukemia. The focus of Dr. Zeidan's clinical and translational research is the development of novel therapies for myeloid malignancies with a special focus on targeted therapies and immune therapy-based approaches. He is also active in health outcomes and comparative effectiveness research for blood cancers and their therapies. It's my privilege to welcome Dr. Zeidan. Thank you for joining us.
Thank you so much, and it's a pleasure to be here with you today. Let me share my screen. Okay, I believe you are seeing the right view. So yes. Thanks again for the kind invitation today, where I'll be talking about MDS, in particular high-risk MDS, as well as AML. And as you can see here, I added the word spectrum because they actually sit on a continuous spectrum, and sometimes it's difficult to distinguish high-risk MDS from AML. And there has been a lot of talk, especially most recently, about how we can try to understand the biology rather than having specific cutoffs in designing the best treatment options for patients. So these are my disclosures. So the objectives of today's talk basically is to understand what myelodysplastic syndromes are, understand the symptoms, the signs, and diagnosis of MDS, to understand how do we predict clinical outcomes and counsel patients about expected course, as well as understand the treatment options, especially for high-risk disease, and understand the evolution to acute myeloid leukemia and how do we manage that. Here you can see in this picture a picture of dysplasia. So dysplasia in the word myelodysplastic syndrome means that the bone marrow cells are growing basically abnormally. So you can see here at the bottom is what a normal cell is supposed to look like, a normal neutrophil. And then you can see here those cells are so abnormal that they were able to find the entire alphabet, basically based on how these nuclei were made. So this is what dysplasia means, abnormal maturation of those cells. So MDS is not really one group, and I actually tend to add the plural at the end, so it's myelodysplastic syndromes rather than syndrome. And it used to be called for a long time pre-leukemia, as well as an anemia. And there was a lot of confusion about the nature of MDS. It's important to realize that it's a form of cancer. So like other cancers, it could be aggressive, it could be more indolent. However, some patients, it could be as severe as acute myeloid leukemia. And this is important to understand because we don't want to basically underestimate it in terms of management. The second thing is that those cells are clonal, meaning that they come from one mother cell. And this is what generally cancers behave like. We see what we call ineffective hematopoiesis. This means that there are many cells in the bone marrow, but they are dying early on and they are not being released in the blood. And what that leads to is basically clinically is seeing low blood counts, what we call anemia, which is low hemoglobin, neutropenia, which is low neutrophils, and thrombocytopenia, which is low platelet count. So the bone marrow is a factory that makes all of these cells. Red blood cells carry the oxygen, so when they are low, they can cause anemia. White blood cells, especially the neutrophils, defend against infection. And platelets basically block the vessels when there's a breakdown in the vessel wall, so they prevent bleeding. So when these platelets are low, people can bleed. So myelodysplastic syndromes are often, most of the time, diagnosed in older patients. The median age of diagnosis is in the 70s. So most of our patients are in their 70s and 80s. However, it can happen at any time. So on occasion, we can see patients who are in their 20s, 30s, 40s. In those situations, we have to think about genetic factors and familial predisposition for it. It's a rare condition. You can see 20,000 cases in the US a year. So that translates to around only 4 in 100,000. So it's a rare cancer. And around 1/3 of those patients will evolve into the more aggressive forms, such as acute myeloid leukemia. So the presentation of MDS is very heterogeneous, meaning that patients present with low blood counts, but this could be very severe where all the blood counts are low, or it could be just one of those blood lineages, for example, anemia. And some patients don't have any symptoms at all. They actually come because someone did a blood work, usually their primary care physician or their preoperative evaluation, and the blood counts were low without the patient having symptoms. The patients end up being referred to hematology. And currently, the diagnosis of MDS requires a bone marrow biopsy. I suspect many of you either have undergone a bone marrow biopsy or have seen a relative being told about it. So you can see here a representation of how it's usually done. So we go to the iliac bone in the low back here, and we go with this needle. There are different types. This is a classical one called the Jamshidi needle. We go through the bone cortex, which is the outer part of the bone where you have all the calcium. We go through it, and then we go to the bone marrow, which is basically what is inside the bone. And we take a sample. We take a liquid sample, and we take what we call a biopsy, which is a more solid sample. And we examine these under the microscope. But also we do additional studies, which I'm going to show you some of, such as cytogenetics and molecular studies, to make the diagnosis of MDS, and not only make diagnosis, but also to understand the expected outcome as well as the different treatment options. So this is a slide that shows you that many conditions can come like MDS. And as someone who sees a lot of patients with MDS, and I get a lot of referrals to my clinic for second and third opinion, it's actually not uncommon that we get patients referred for MDS and they turn out to have something different. Some of the common things that can lead to that are nutritional deficiencies, B12, folate deficiency, sometimes copper deficiency in people who had malabsorption situations, or people who had, for example, gastric bypass. Some medications, HIV medications, some myelosuppressive medications, methotrexate, azathioprine, lead and zinc poisoning, alcohol abuse, some rheumatologic conditions such as lupus, rheumatoid arthritis, or immune conditions, other hematologic malignancies, other forms such as myeloproliferative neoplasms. So all of these conditions can mimic MDS, and it's very important to understand if this is truly MDS or not, because the treatment can vary significantly. And this is another representation basically of MDS and the overlap with other forms of blood conditions, including acute myeloid leukemia and myeloproliferative neoplasms. And you can see sometimes this is a clear-cut case, for example, of MDS, but sometimes there's significant overlap with these other conditions. And this is why being seen in a tertiary center, in an academic specialized center, is always very important. I always encourage patients to ask their doctor if they are seen in the community to consider referring them so that the diagnosis can be confirmed. They can hear about treatment options and potentially about clinical trials from a specialized, not only the physician, but also the pathologists. The people who review the slides are also very specialized to make sure the diagnosis is not mixed with something else. So I mentioned to you that we do some studies from the bone marrow. This is an example of a karyotype. Karyotype, basically, we take some of the cells from the bone marrow and then we culture them. And then we look at the chromosomes inside these cells. And you can see here, this is how a normal chromosome spread would look like, two pieces or two copies of each chromosome, with the exception here of 3 copies of chromosome 8. So this is the abnormality here at trisomy 8. It's important to note that there are many different abnormalities that can be seen in karyotypic studies. However, none of them are 100% diagnostic. Like you don't find something in particular and say, okay, this is MDS. So it's a situation where you look at the different clinical as well as the molecular and the cytogenetic data to reach a diagnosis. Another study that you will often find is called FISH, fluorescent in situ hybridization. So in this situation, this is faster than the karyotype, and we use specific probes. So the probe would look at a certain part of the chromosome, and it's attached to a dye that basically a fluorescent dye. So this is what you can see here. For example, in this situation with trisomy 8, you can see that there are 3 copies of chromosome 8 instead of 2. So what are the different types of MDS? So there are 2 general big groups of MDS, what we call primary, which is someone who basically doesn't have a specific reason why they had MDS de novo or idiopathic, or secondary, and this occurs in patients who have previous exposure to radiation or chemotherapy, and this can be generally more severe, and we often see that in patients, for example, who had breast cancer or who had prostate cancer, or they had received radiation for other conditions such as lung cancer. Sometimes people get DNA damaging agents for multiple sclerosis and other non-cancer conditions, and sometimes it's occupational. So people who work with benzene or who have exposure to a lot of radiation can develop MDS. And once we make the diagnosis of MDS, the next step is to diagnose it. So this is a busy slide. Again, I'm showing you this slide because you probably, when you see your pathologic report or your family's pathologic reports, you can see a lot of these descriptions on the slide. And this shows you the evolution of these terminology for MDS we had since the initial descriptions in the 1970s. And the first classification, we had what is called the French American British classification. We had these groups. It used to be called refractory anemia. So refractory anemia used to be a term because those patients had anemia, but it would not work by giving them iron replacement, or in the past they used to give liver, for example, to correct the iron replacement. Those anemias would not improve with nutritional supplement. So this is why they used to be called refractory. However, now we have good treatments, so the term refractory anemia is not used right now. It has been replaced in the most recent classification to MDS with single lineage dysplasia. However, you can still see it in a lot of the papers, in the FDA approval for some drugs, and still in the pathology reports. So I think it's important to be familiar with these terms because you still see them. Another important term is refractory anemia with excess blast. So this is when you have an increase in the number of the cancer cells in the bone marrow. 5 to 9% is excess blast 1, and 10 to 19% is excess blast 2. And why is that important? Because as we discussed at the beginning, AML and MDS occur on a spectrum. If you are at 20% or cross 20% currently, you are diagnosed with acute myeloid leukemia. If you are less than 20%, you are having MDS. Of course, that's with the caveat, as I mentioned, is that these, we think of them more and more as arbitrary cutoffs, meaning that some patients might have less than 20% blast, but biologically they are behaving like acute myeloid leukemia. And there are a lot of initiatives to try to revisit the issue of how to define AML and MDS, but that, I think, is beyond the scope of our discussion today. So in addition to the classification of MDS, also we do look at the prognostic systems. So what is a prognostic system, or a scoring, what we call a prognostication tool or risk stratification tool? So this is basically a calculator that we use so that we can tell a patient when we see them, this is your expected survival, and this is what is expected in terms of when do you develop, or if you develop acute myeloid leukemia. So you can see a number of those: the International Prognostic Scoring System, the revised IPSS, which is a revised version of the IPSS, the WHO Prognostic Scoring System, and the MD Anderson Prognostic System too. All of these, again, and there are many others that I'm not showing, but these are the most popular ones. Usually we'll look at how many cancer cells are in the bone marrow, what we call the blast, and you can see here less than 2%, 2 to 5%, and then you get a score. You look at the cytogenetics, at the karyotypic abnormalities, what I showed you earlier. For example, do you have trisomy 8? Do you have complex karyotype? Do you have deletion 5q? And then this get classified in a group based on the clinical outcome, and then you get a score. And then you have the cytopenias, and this is basically how low are the blood counts, the hemoglobin, the platelets, and the neutrophils, and you get a score. And then these get added together, and then the patient is assigned into a group: very low, low, intermediate, high, and very high. So no matter what tool you are using, basically, at the end of the day, most patients will be classified either as lower risk or higher risk MDS. And we are going to talk about why this is important, because it affects the goals of the treatment and the specific therapies that the patient would get. Important from a patient perspective is that when you go to your doctor, I think it's important to know what is your revised IPSS score, to know what is your blast count, what is your cytogenetics, and which risk group you are in, because that can give you a general guidance about what do you expect in terms of the clinical outcome. With the caveats that I'm showing here at the bottom is basically none of those those are statistical models, meaning that if you take 100 patients and you say the median survival, let's say, is 40 months, that doesn't mean a particular patient that you are talking to in the clinic is going to expect to live 40 months exactly. That means if you take 100 patients, half of them would expect to live less than 50 months, and the other half, they will live more than 40 months. And any particular patient, we don't know where they exactly live on, but it's a general guidance of where someone would sit in terms of their expectations. So this is a schematic presentation of what I mentioned to you earlier. Based on your risk group, you can see the overall survival, and clearly as the risk group is worse, basically, you can see that the survival here is the worst at the bottom, and that also is seen in the table. In the very high risk groups, and this is for patients who do not receive treatment, just transfusions, in the very high risk group, it's only less than a year survival, while patients with the very low risk group, they can live a median of 10 years. So some patients can have a long survival with just blood count monitoring. So MDS is somewhat unique compared to other cancers in the sense that there's a huge variation in the expected outcome of patients. And this is also showing the chance of development of acute myeloid leukemia. And as you can see here again, the higher the risk group, the faster the time to developing acute leukemia. But again, important to remember, only 1/3 of patients with MDS develop acute leukemia. So most patients will not develop acute leukemia. And that's important because many patients still die from MDS from the complications of the low blood counts. So the goal of the treatment in high-risk MDS is not only to prevent going to acute myeloid leukemia, but also to reduce the chance of dying from complications of the bone marrow failure. When we talk about bone marrow failure, as I mentioned at the beginning, it means that the bone marrow is not making the red blood cells, so it's not doing its job. And similar to how you think about kidney failure or liver failure, where the organ is not doing what it's supposed to do. So we talked about the karyotypic abnormalities. So those at the level of the chromosomes, and you can see here a full chromosome here. However, chromosomes, as many of you know, are made of a large number of individual genes. You can see them basically in the DNA. And now we know that around 50% of patients with MDS have abnormalities in the chromosomes, but the other half do not. And this was puzzling for us for many years. However, once we have better scientific methods to look at higher resolution, basically having a better look at these chromosomes at the level of the genes, now we found out that many patients, up to 90 or more, 90% of patients, will have an abnormality at the level of the genes. And those abnormalities are what we call somatic mutation. A somatic mutation means that it's a mutation or an alternation in the DNA that developed in time. It wasn't passed on from your parents. Germline means that it was present early on from the very early phases of development of the embryo. And those sometimes are passed from generation to generation. Most of the MDS mutations are somatic, meaning that they are acquired through life and they are not something that you are born with. And you can see here in this busy figure that there are many, many different genetic mutations. And now we have more than 40 different genes that are recurrently abnormal, meaning that we see them in MDS patients. The size of the circle correlates with how often do we see these genes. So you can quickly look at this and realize that SF3B1 and TIT2, ACXL1, and DNMT3A are some of the most common found genes. And you can see here the different pathways that these affect at the level of the cell: transcription, epigenetic regulation, as well as DNA repair, such as TP53. So this is very important because now we understand that those mutations, which, as you can see in this figure, there are many of them. And one of the problems in treatment of MDS, when we say it's heterogeneous, meaning that there are many different alterations that drive MDS. For example, in chronic myeloid leukemia, you have only Philadelphia chromosome, which is a translocation between chromosome 9 and 22. While in MDS, you can see a very long tail. Only 5 or 6 of these occur more than 10% of the time, while the vast majority of these abnormalities occur in many or occur in few patients. So therefore, it's very difficult to apply the concept of precision medicine, meaning that I'm giving a treatment that is directed to the specific alteration that the patient has. However, now, as I'm going to talk to you later in the talk, we are finding out that some subsets, for example, if you have an IDH mutation, as you can see, that can happen in less than 5% of patients, potentially could benefit from some of the newer treatments. SF3B1 mutation, this one, has been correlating also with response to a drug called luspatercept. So we are starting to go there, but it has been a slower process than other cancers. So we talked about how do you diagnose MDS, how do we make sure it's not another condition mimicking MDS, how do we classify MDS, and how do you think about the risk stratification, or trying to understand what is the expected outcome from a clinical point of view for the MDS. And the next question that always comes is how do you treat it, of course. And as I mentioned, MDS is special in the sense that the treatment varies significantly because the patient presentation and their expected survival vary significantly. So some patients don't have any symptoms. Their blood counts are slightly low, but they are not needing transfusions. And those patients can be monitored, while there are patients who have very severe low blood counts and very high platelet count. They are almost as sick as acute myeloid leukemia patients. So how do we decide? Basically, for high-risk MDS, the goal is to prolong survival, improve quality of life, reduce transfusions, reduce chance of progression to acute myeloid leukemia. And the treatment decision usually is affected by the factors I mentioned earlier, but also what we call patient-specific factors. For example, the age of the patient, how the performance status, which is a functional measure, whether the patient is in a good physical condition or not, as well as their treatment goals. So you can see in this busy slide basically a representation of the different treatment options. So you can see the biggest distinction is whether the patient has lower risk MDS or whether they have higher risk MDS. And for the lower risk MDS, usually the anemias are treated by a group of drugs called erythropoiesis stimulating agents. If the patient has ring sideroblast and they have not responded to erythropoiesis stimulating agents, a drug called luspatercept has been approved by the FDA for those patients and it's currently available. There is a drug for a specific subtype of MDS called deletion 5q called lenalidomide. So all of these are options for lower risk disease. For high risk disease, we always think about transplant as well as the use of hypomethylating agents. And I will talk about some of this in the details. And you can see here also a description of those different options. Of course, I always like to highlight that clinical trials are very, very important because this is how we find new agents that hopefully can help the patients. So as we mentioned, anemia is very common in MDS. Most of the patients will have anemia, and most of them, or many of them, will become transfusion dependent, meaning that they need red blood cells to stay in reasonably good shape. Some patients can need as frequent as 1 unit every 4 weeks or 2 weeks, and some patients need 1 unit every 3-4 months. So it varies significantly. However, the more severe the anemia, the more frequent the transfusions are needed. Usually the worst quality of life for the patient. And ESAs, some of you might be familiar with two main versions that are used, Procret or Epoten, basically. This is the short-acting version of erythropoietin, and then there's a long-acting version such as darbepoetin, and those can be given either every 1, 2, or 3 weeks, and usually they work, if you look at all patients, in around 40% of the time. They tend to work best if the patient does not need a lot of transfusions and they have lower erythropoietin levels. Lenalidomide is an oral drug. This drug works best for a subtype of MDS called deletion 5q. When you have that specific alteration, the chance of response is almost 67%, meaning that more than 2/3 of the patient will become transfusion independent. They stop needing transfusions when you give them the drug. Compared to the erythropoiesis stimulating agents, lenalidomide is actually a pill. You can take it by mouth. Luspatercept is another drug that is used in MDS. This was only approved in 2020, so it's relatively recent in the market. This is an basically it's what we call a trap. How does it work? Is it binds to proteins that suppress the bone marrow. Those proteins are called transforming growth factor pathway superfamily ligands. They go to the bone marrow and then they suppress the ability of the bone marrow to make red blood cells. So this recombinant fusion protein binds to these bad actors, to those ligands, and therefore releasing that inhibition on the bone marrow. In early trials, it has been shown to work in patients who need frequent transfusions, in particular in patients who have a subtype of MDS where they have ring sideroblast, and that happens a lot in patients who have SF3B1 mutation. Iron chelation is something we think about often in patients because iron can build up in the body. There is no normal physiologic mechanism in our bodies to get rid of the iron. So if you keep getting red blood cell transfusions and every unit of blood has iron in it, around 250 milligram, this can build up in the body. So in patients who continue to need transfusions, especially lower risk patients, we tend to think about using iron chelation, which are pills that can bind to the iron and can get rid of the iron. However, they come also with some toxicities, and it's important to think about the risks and the benefits of using them for any individual patient. One problem we have also in lower risk MDS and also high risk MDS is severe thrombocytopenia when the platelet count is very low. So this is one of the challenging situations to actually target in patients with MDS. However, this is one drug, for example, that is used, and again, this is off-label use. This is not an FDA-approved indication, but eltrombopag is a oral pill that in some patients with lower risk MDS, especially if they are older and they don't have a transplant option, or if they do not benefit from hypomethylating agents, this pill can help the platelet count. However, it's important to monitor these patients closely because in some patients it can cause some scarring in the bone marrow, what we call fibrosis, and there has been concern it might affect the blast in the bone marrow. So it's something, again, to be aware of and discuss with your doctor if you have very low platelets. I think this slide is very important. This is describing clinical trial, basically, that looked at going to transplant for patients who have donors versus just continuing on hypomethylating agents. And why is that important? Because this trial allowed patients up to the age of 75. Many patients are seen in the community and they are 65 and they are told they are too old for transplant, which is not correct. Now we can transplant patients up to the age of 75, depending on the institution. Some of them do it early 70s, but we generally look at the overall health of the status of the patient. If the patient is in reasonably good health, we certainly would consider bone marrow transplant. And this study has shown that the 3-year survival is around 50% for patients who undergo transplant compared to 25% for those patients who don't undergo transplant. So clearly, it's important to think about transplant. And this is another reason why if your doctor in the community does not refer you to a big center, you should ask about being referred, because clinical trials and transplants are things that we offer. So what do we do before transplant for higher risk patients? What we do is drugs called hypomethylating agents. Azacitidine is one of them. This is an injection that's given in the vein or under the skin every 7 days and has been shown to improve survival in patients with MDS. Another one is called decitabine. This is a cousin of azacitidine. Actually, azacitidine, when it's taken in the body, it gets metabolized to decitabine. So decitabine, in contrast to azacitidine, has not been shown to improve survival, but it reduces the cytopenias and improves the quality of life. Many of us think that the reason why survival was not improved is related to the design of the trials, but there's increasing evidence that azacitidine and decitabine are very similar in their efficacy, and there's actually a lot of non-randomized clinical trial data that suggest that, and both of them are approved in the US for treatment of MDS. The newest version of a hypomethylating agent is actually an oral drug. So both of the first two drugs I showed you, azacitidine and decitabine, are intravenous. Aztec 727 or sidazoriden decitabine, this is an oral version of decitabine. The reason why you could not take decitabine orally is that it gets consumed in the gut, what we call first pass effect. It gets destroyed in the gut and the liver. So we have an inhibitor of this enzyme that does that, which is called cytidine deaminase. So when you combine that with decitabine, the sidazoriden will inhibit the cytidine deaminase, and therefore decitabine will not be destroyed before it reaches the body. And this oral version of decitabine has been tested in a randomized clinical trial called the Ascertain, which has been presented more than one time. And the data suggests that the activity is actually very similar to the IV decitabine. I have to say here that the trial was looking at the pharmacokinetics, meaning the level of the drug in the blood between the oral and the IV decitabine. However, we know from following patients on this trial that the rate of the complete response is around 20%, which is similar to what we see with IV decitabine. And we have also recent data from the American Society of Hematology showing that the drug has activity in lower risk MDS, but there are ongoing trials to better understand the dose in lower risk MDS. Those drugs, all hypomethylating agents, can cause fatigue, can lower the blood counts, can lower the platelets and the neutrophils. They can cause infections. So those patients have to be monitored closely, even if they are taking the oral version of the drug. I'm showing you here some of the most recent drugs that are in clinical testing, such as venetoclax. This is an oral pill that's approved for acute myeloid leukemia in combination with azacitidine. And this is again a busy kind of scientific slide showing how the drug works, and that in preclinical data before the clinic, there was synergistic activity. And there has been 2 trials that were presented recently. One as a first-line treatment, meaning when the patients are newly diagnosed, where it's combined with azacitidine. And you can see that the response rate, the complete response rate, appears higher, 35%, compared to not having, and this is a single arm study, it's not randomized. So we clearly need longer follow-up and more data. But also after the venetoclax stops working, we have some data, which I'm going to show you in a minute, that shows it's active in that setting as well. Here you can see some of the risks that come with venetoclax, such as infections and bleeding. Again, these are very common to all kinds of treatments that we use for high-risk MDS. Here I'm showing you some data that we presented on behalf of co-authors, where adding venetoclax in the refractory setting after the azacitidine stops working basically can lead to complete responses as well as transfusion independence in some patients. However, again, venetoclax is not approved by the FDA for MDS, and all the work is actually in clinical trials. So right now, for example, there's ongoing randomized phase 3 trial called the Verona trial, which is available in many centers across the country, where patients receive azacitidine and venetoclax, or azacitidine with placebo, with the idea of seeing if their response and survival is improved. Another, I think, exciting group of drugs are called immune checkpoint inhibitors. You probably have heard about this because they have received a lot of publicity for solid tumors like lung cancer and skin cancer, where they unleash the immune system. The immune system in patients with cancer stops doing what it's supposed to do and clean the cancer cells, which lead to their growth. And there are a group of drugs called monoclonal antibodies that can stimulate the immune system so that it can go after the cancer cells. We have done several of those trials already. Some of the classical immune checkpoint inhibitors that are approved for solid tumors, such as durvalumab, did not work for patients with AML and MDS when we added it to azacitidine. However, there are a number of newer agents that are being tested. For example, one of them is sabatolimab. This works on a receptor, on a protein called TIM3, to activate the immune system, but also it directly affects the leukemia stem cell. Some early data was presented in the American Society of Hematology meeting, where it showed that the side effect profile is actually similar to what you would think you would get with azacitidine alone, meaning it does not adding the antibody does not increase the toxicity by much, and it has early activity in especially in patients who have poor risk karyotype or adverse risk mutations such as CP53. But again, this is also like the venetoclax trials I just showed you. It's a single arm study. It's still ongoing and not many patients. So there are a number of ongoing randomized phase 2 and 3 studies. For example, the Simulus MDS1 and Simulus MDS2, both of these are in advanced stages of, or actually they are completely accrued basically. So they failed, but we are waiting for the results because they have not yet been mature enough to give us the results. Other drugs that are in clinical testing, the IDH2, this is an oral pill that works against a mutation called IDH2, which is present in patients with MDS in around 5% of patients. And it's approved for AML, but not in MDS. However, if you do have the mutation, we have data, for example, some of this data that was presented by French group in American Society of Hematology meeting showing activity here. Similarly with the IDH1 mutation, which again happens in around 2 to 3% of MDS patients, with a different drug called ivosidenib, it seems to work. CPX351 or liposomal daunorubicin with cytarabine. This drug also is approved for AML, but not in MDS, and it's being studied in MDS and some early data. Also, I didn't show you data about a drug called anti-CD47 or magrolimab. This is a drug also that stimulates the macrophages against the cancer cells, and also had early data suggesting activity, and is currently in randomized clinical trials. However, I think it's very important because the outcomes with the drugs I showed you, the azacitidine and decitabine, are not sustainable for a long time, and many patients don't respond. And if they respond initially, many of them will lose responses later. So I think it's very important to think about clinical trials where azacitidine or decitabine is given with another drug. Those combinations, I think, are the way to improve the outcome of patients on the long run. Now, switching gears in the last 5 to 10 minutes to talk about acute myeloid leukemia, because as I mentioned, this sits on the spectrum of high-risk MDS and AML. In acute myeloid leukemia, the treatment is somewhat historically different. So patients who are able to receive intensive chemo, what we call induction chemo, and that's determined by a large number of factors that you can see here, we would recommend going for, in many situations, to go for the strong chemo, which is a drug given for 7 days, and the other drug was given for 3 days, cytarabine and daunorubicin or idarubicin. This is why it's called 7+3. And this, as you can see, actually has been the treatment since the 1970s. This combo has been used for more than 45 years, and we were like frustrated for a very long time because we did not have new drugs that could improve the outcome of patients. And not only that, that many patients, especially older patients, as you can see in some of the real life analysis that we've done, don't tolerate these intensive treatments very well. So you can see that fungal infections occur in around 20% of patients, around 10% even of younger patients could die from this intensive treatment, and even higher among patients who are older. So we've been thinking about treatments that are, especially for older patients, that are not as toxic and somewhat more effective. The two drugs I showed you earlier, azacitidine and decitabine, are also used in acute myeloid leukemia for older patients, but the outcomes with them are not particularly great. You can see here in these important trials that the survival is generally less than a year. However, they lead to responses in many patients with around 20 to 30% complete response rate. And as I mentioned earlier, our data suggests that the two drugs are not that different. I get this question very often from patients and doctors in the community about which drug to use, and I always say either one is fine. However, the most important thing is that to use a drug, because until now, there are actually a lot of real life analysis. This is an example of one that we have done, showing that patients do not respond to active, or many of them don't get intensive chemotherapy, any kind of therapy, not only intensive treatment, but even hypomethylating agents, more than 50%. However, this trial, as you can see, or this study was up to the year 2013, where still 40% were just receiving supportive care. Now we are hoping, as I'm going to show you in a minute, that since we have many more newer treatments, that more patients will be treated. So why many patients who are older don't get treated for AML? I think many of the patients have other medical problems. AML in older patients tend to be generally more aggressive, and generally you cannot cure most patients. There is a lot of fear of toxicity, and sometimes the patient themselves don't want specific treatment. Sometimes there's a lack of social support. There are a lot of visits required to treat acute myeloid leukemia. You need to come for blood transfusions and monitoring, etc. And since many of the patients are older, their husband or a wife could be disabled or dead, basically, and they don't have that support. Like the children are out of the home, so they don't have someone to help them back and forth, etc. And the second factor is that, as similar to what I showed you in MDS, in AML also there are many different alterations that drive AML. So what we've been doing for a long time, which is giving either the strong chemo or the hypomethylating agents, is probably not the best strategy, because there's a lot of diseases within AML, what we call genetic and biologic heterogeneity, meaning that probably the best way to approach this is to try treatments that might work for specific subsets. And the last point, I think, for why the treatment outcomes have not been particularly great in older patients with AML is that the traditional endpoint, how do we measure the success of a drug called complete remission or CR? Basically, to get to a CR, you just need to go to less than 5% of tumor cells in the body. So it's like this iceberg where you are just seeing the top of it. And there are still many cancer cells in the body that you're not seeing even when you achieve this complete remission. And this is why many patients, even when they achieve complete remission, the disease would still come and many times they would die from it. So we need better treatment that not only go after the tip of the iceberg, or in another analogy I give to patients, the tree, but you also need to go at the roots of the tree so that it doesn't grow back. Some of the newer treatments have given us hope and to the patients about better outcomes. I mentioned venetoclax to you already in the talk. We have two randomized trials, especially the VIALE A, where patients who received venetoclax with azacitidine had improved survival. However, it's not a panacea. You can see that the survival is 15 months. However, it's still better than azacitidine alone. So this has become a standard of care for older patients who cannot get the intensive treatment. And we historically had a lot of headaches with finding new drugs for acute myeloid leukemia because, as I mentioned, you have a lot of these relapses where I tell people it's almost like a whack-a-mole type of situation where you hit one mutation and then you have another one rise up and cause the relapse. So we needed more drugs that can hit the different mutations. And now we are actually starting to get there, where you can see here some of the drugs that have been approved in the last 5-6 years for acute myeloid leukemia, starting in the year 2017, where midostaurin was the first drug to be approved in the US. And then you have a number of drugs. CPX, we talked about this drug, Glastigib, which is a hedgehog inhibitor, the IDH1 and IDH2 inhibitors, venetoclax, oral azacitidine, gilteritinib. This is a FLT3 inhibitor, a drug called gemtuzumab, ozogamycin. So since 2017, we have 9 new drugs approved for acute myeloid leukemia, and we are starting to see outcomes already improve for patients, where the goal is, while you might not be able to cure leukemia in many patients, the goal is to try to prolong survival as much as possible, maintain quality of life, and be able to go from one drug to the next, hopefully transforming some of those diseases into chronic diseases, almost like what's happening in multiple myeloma, where patients are not cured, but they can live on average 8 years. And this is what we are hoping to do with AML and MDS over time. But what this has resulted into is that the treatment decisions for acute myeloid leukemia have become very complicated. As you can see, there are many different combinations. I joke that you need almost a GPS now to drive you through the different treatment options for AML. And why is that important? Because I think it's very difficult in the community level for the doctors who see not many patients with AML or MDS to keep up with all these new treatment options. And that's another reason why I think it's important to think about talking to someone in an academic center, not only about the available treatment options, but also about potential clinical trials. So this is my last slide. These are my funding organizations and the groups I worked with, and as well as my Twitter handle and my account, and happy to give any answer any questions that you might have. Thank you so much.
Thank you, Dr. Zeidan, for the wonderful presentation. We have quite a few questions. So our first question is, how often would you check labs for a patient who is being treated with venetoclax and Vidaza?
Yeah, so as I mentioned in the talk, venetoclax is not treated, is not FDA approved for MDS. So I'm not sure if this patient, what you are describing, are we talking about MDS or AML? But if it's either way, if venetoclax is used, the patient should be checked quite frequently, especially in the first 2 to 3 cycles. So early on, you have to monitor for something called tumor lysis, and those patients will need daily labs, and sometimes they need to be hospitalized depending on their kidney function. depending on how they do. Many places will hospitalize them. Other places will monitor the patient outpatient closely. The patient come every day for the azacitidine and blood work monitoring. They have to be taking a drug called allopurinol to protect the kidney, and if they get sick, they have to be hospitalized. After the initial phase, generally the patients will need 2 to 3 times a week blood work to give, so that you can give them blood transfusions, platelet transfusions. They have to be on antibiotics orally to reduce the chance of infection. If they have a fever, they have to be hospitalized. So the treatment is quite involved and requires a lot of visits back and forth to the hospital and sometimes admission. However, if the patient achieves a complete response, and that can take, sometimes 2 months, around two-thirds of the patients, or one-third will achieve a complete response, two-thirds will achieve some kind of a response. The frequency of the labs becomes less frequent once you are in remission. So that can be once a week or once every 2 weeks, depending on the blood counts and the specifics of the situation. One last thing I like to mention about venetoclax is that it has a lot of interactions with other drugs such as antibiotics, and so it's very important for the patient to tell the doctor about all the medications they are taking, because sometimes this can affect the dose of the venetoclax. And if any other specialist who's treating the patient, like example, if you have a heart doctor who want to give you a new heart blood pressure medication or some other, it's very important they talk to your oncologist or your hematologist to make sure that drug does not interact with venetoclax, or if it does, to make the necessary adjustments and implement the necessary monitoring.
Thank you. Our next question: in patients with MDS with 15% blast, severe neutropenia, transfusion dependent, and severe cold agglutinin disease, which would you treat first? And second part is, can you give Vidaza and prednisone at the same time?
You can give both. I think the bigger question again is whether you are talking about a curative situation where your goal, and this is usually the goal in a patient with MDS, like what you described, that's higher risk, and those patients are at high risk of dying from their disease and complications. So we generally try to go for a bone marrow transplant. So generally we'd be giving azacitidine or decitabine and then try to go for a bone marrow transplant. I think it's when it's not a curative situation, the patient is either too old for a transplant or they have other comorbidities. Usually, we try to focus on the more acute, like what is causing most of the symptoms or the severity in terms of complications to the patient. But ultimately, you can give steroids. The only problem is that if you give steroids for a long time, patients can have, you can increase the risk of infections. Of course, chronic steroid use comes with its own risks and benefits. So I think it's something that is very important to individualize based on the specific situation of the patient, not only the disease, like what you described are the disease characteristics, but also the patient, what are their comorbidities, what other medical conditions, other medications, what's the goal of the treatment. All of these are very important.
Thank you. For a patient who has high-risk genetic mutations such as TP53, RUNX1, and ASXL1, do you recommend post-transplant preventative therapy?
That's an excellent question. So currently there is no standard of care for what we call maintenance, which is post-transplant therapy. However, we know that the most common reason why transplant doesn't work, unfortunately, is MDS or AML for that matter. Many times they would come back, especially in patients who have high-risk alterations such as the ones you described. So while the standard of care is not to use maintenance, I do discuss it on a individual, like patient by patient basis. For example, in a younger patient who potentially can come for maintenance, I would consider it. However, we currently don't have approved drugs, so people sometimes use, like if the patient has an IDH mutation, Sometimes they think about continuing that after transplant. Sometimes we think about using hypomethylating agents similar to what they had before the transplant. However, I think the best way to do this generally is in the context of a clinical trial, because again, we don't know at the patient population level that maintenance does help, but I do consider it on a patient by patient discussion. Last point I like to make here is that those maintenance strategies can lower the blood counts, and patients post-transplant, their bone marrow might be suppressed, and they can run into issues of infection and bleeding and other things. So again, that can complicate the discussion. So the patient has to be in good shape, good blood counts, the bone marrow has taken in, no graft rejection, ideally no graft versus host disease. So all of these things are important to think about when you think about maintenance.
Thank you. Our next question is, for patients with AML and pancytopenia, are they at risk for tumor lysis syndrome with venetoclax and Vidaza?
Correct. And this is important to note that, some people think they look at the blood count and, the blood counts are low, so there is no tumor lysis risk. That's actually not correct, because most of the leukemia cells sit in the bone marrow. So although the blood counts might be low, it's true that when the white cell count is very high, the risk of tumor lysis is higher, and we try to reduce the white cell count before we give the venetoclax with, for example, with hydroxyurea. However, people should not be deceived into thinking that there is no tumor lysis risk just because the blood counts are low, because there are still many leukemia cells in the bone marrow. So there are other things we look at. For example, the kidney function. Someone whose kidney function is not great to start with, they are at high risk of tumor lysis. Someone who has a high level of markers such as uric acid, LDH, those patients are also at risk of significant tumor lysis. So we generally implement measures in all patients, but especially the ones who are at higher risk, giving them fluids, which could be oral or IV, frequent monitoring of the blood work, which could be multiple times a day, again, depending on the situation. Sometimes you have to admit the patient. But the short answer is that every patient with AML who gets venetoclax, or MDS for that matter, if it's used off-label, could be at risk of tumor lysis, and there should be close monitoring and all these measures I mentioned, including potentially hospitalization for monitoring, even if the blood counts are low, because patients could still have tumor lysis.
Thank you. Our next question is it safe to give GCSF in a patient with MDS with excess blasts and who is severely neutropenic?
Yeah, that's actually a very interesting question, and there are different practices. I generally don't use GCSF in this context because GCSF can also stimulate the blast cells, and it can worsen the outcomes on the long run for patients with MDS. So I would not do it as a treatment for sure, in the sense that you are giving it for a patient who's looking well or after azacitidine. However, the only situation where we think about it is in patients, for example, who are getting, let's say, azacitidine and venetoclax, and we do a bone marrow and they are in remission. So the excess blasts are gone. We're not seeing them. And they are neutropenic. Then you can think about giving them GCSF to try to stimulate those neutrophils to come back. But generally, I would not give it to someone who has increase in the blast and they are still there. The blasts are there in the bone marrow and the blood. Except in a situation where the patient is super sick, they are admitted, for example, to the ICU, and they are developing a resistant bug, and where it would be more of kind of a late intervention, because generally, as I mentioned, we are concerned that on the long run it might worsen their outcomes.
Our next question is, why do MDS patients not get infections despite being severely neutropenic?
I mean, I have to say that patients do. I mean, not all patients don't get infections. It's true that some patients might not get them, but many patients actually do get infections. And if you look at MDS, and I think I mentioned that at the beginning, is that while most patients with MDS will not progress to AML, most of them still die from MDS, with especially the high risk disease. And the reason why people die from MDS are usually complications of bone marrow failure, which is infection, bleeding. So I don't think people should think that neutropenic patients with MDS don't get infections. So they get infections, but it varies between different patients. Some patients can have low neutrophils for a long time and they don't get infections, but many patients can still get infections. So overall, we certainly see a lot of infections in MDS patients.
If the bone marrow has mild dysplastic changes and yet has multiple MDS defining mutations, would you still call it MDS?
So currently, to diagnose MDS, you have to meet three things. You have to have low blood counts, and this is where it gets confusing, because sometimes you could have those mutations in the blood, but you don't have low blood counts. And that could be a situation what we call increasingly recognized as CHIP, clonal hematopoiesis of indeterminate potential. Sometimes you have low blood counts and you have the mutations, so that is called CCUS, or clonal cytopenia of undetermined significance, but you don't have the dysplasia and you don't have the karyotypic abnormalities to define MDS. So currently you cannot define MDS except in patients who have SF3B1 mutation or deletion 5q based on those molecular alterations, except if the patient has dysplasia uh, and they have to have the low blood counts.
Our next question is, what are the side effects of luspatercept, and do they lessen the longer it is taking? What is your feeling about using this treatment if a patient has been a stroke victim in the past?
Yeah, so luspatercept generally, like, it was studied extensively in the Middle East trial. And the main side effects that were seen on that trial were fatigue, which tend to be more in the first few months of the treatment. And it usually, in many patients, it gets better over time. Other things that has been seen are increase in blood pressure. Rarely there could be GI upset, some muscle aches, some rashes, things like that. Serious side effects in general are not very common. They could include renal issues or rarely cardiovascular, but generally those are not common. So I think it's a patient by patient situation. I usually will discuss those side effects, and depending on what is the profile of the specific patient and what other options they have. But overall, the risk profile of this drug, is generally not very toxic compared to chemotherapy or some of the other agents we use for MDS.
In which patients would you start Dacogen rather than Vidasa?
Yeah, and as I mentioned, I think this is evolving. In general, I tend not to think too much about these two drugs are very different. So the main difference is that Dacogen is IV and is given for 5 days, while azacitidine could be given IV or sub-Q and is given for 7 days. So sometimes there could be insurance differences in which one is covered. It could be that the patient doesn't want to get anything IV. They only want sub-Q because it's faster. They don't want to spend like 2 hours in the clinic. They want to come for 15 minutes. So in that situation, you can do azacitidine because it's an IV. It's a sub-Q. You can give it sub-Q, while decitabine you cannot give it sub-Q. And of course, in addition to these two injectables, we have the oral version of the decitabine, which also is for 5 days. So I think we have a number of agents, and I think of them very similarly. So I think I generally look at the logistics and rather than the efficacy. I don't think of them as very different in terms of efficacy, more about what is easier and logistically feasible for the patient.
Thank you. How many cycles of Vidasa are typically given before transplant and in a high risk MDS patient?
So it varies. I mean, hypomethylating agents can be slow to work in terms of how quickly you get into a response. So it can take 4 to 6 cycles before you see a complete response. Some patients, on occasion, can respond after 1 or 2 cycles, especially if if venetoclax is added. Sometimes we see faster responses. Again, that's off-label use. But I would say if the patient is going to bone marrow transplant, generally, if the blood counts become normal, I would do a bone marrow biopsy then. Some people do it after 2 cycles, after 4 cycles. But I think generally most patients will need close to 4 cycles to respond, 4 to 6 cycles, which is around 4 to 6 months.
Thank you. Do you prescribe prophylactic antibiotics and antifungals in patients with severe neutropenia and getting venetoclax and Vidasa?
I do, and actually even with HMAs, if the patient is getting any kind of treatment, azacitidine or decitabine, I do tend to use prophylaxis. The evidence supporting the use of prophylactic antibiotics is stronger in acute myeloid leukemia for this combo, but we still use it in MDS. In my experience, those patients can be at risk of infections, as I mentioned. Important to adjust the doses, for example, if you are using antifungal, monitor the dose levels, monitor interactions with the other drugs, educate the patient that even if they are taking oral antibiotics, if they have a fever, they still need to come to the emergency room. If the patient is not getting hypomethylating agents and they have low neutrophils and they are not on treatment because it's not severe, I don't always give them antibiotics. But if the patient develop an infection, a significant infection, then I tend to use it after that, what we call secondary prevention rather than primary prevention.
This question is in regards to some of the charts that you showed about transplant for older patients. So the question says, is the survival rate of transplant for older patients worth the risk of the transplant? The numbers are confusing.
Yeah, that's actually, that's the center of all the discussions we have about transplant. So I have to say again, it depends on the individual risk of the patient. The way I think about it is that if I look at a patient and I see what is their expected survival if they did not have the MDS, are they in relatively good shape with that, forgetting about the MDS, like from diabetes, hypertension. So you see someone who's 72 but otherwise in pretty good health, and this person potentially could live another 15 years if they didn't have the MDS. With the MDS, if we did not go for transplant, high risk MDS, we know that it's extremely unlikely that patient would be alive beyond 3-4 years at most without transplant. So I think in such a patient, I strongly would recommend transplant. On the other hand, in a patient who has a number of chronic problems and diabetes and hypertension, and so their survival if they did not have the MDS, would probably not be more than 5 to 10 years. Maybe it doesn't make a lot of sense to go for transplant. But this is a very individualized discussion, I think, that should involve a transplanter as well. So many doctors who treat MDS and AML don't do transplant as well. So you are going to talk to both the MDS and the AML doctor as well as the transplant doctor, so you can hear it from both groups and have a better explanation of the risks and the benefit ratio that in terms of how we make these decisions.
Thank you. This question is in regards to the IPSS chart. They'd like to know, how do you know what level of cytogenetics you have and where it falls on the chart?
Yeah, I didn't because I had many slides, I did not show that, but there's actually, if you they are standard charts. If you Google it, it's actually very easy to find. where what is the specific alteration that you have is classified as, poor, very poor, good, so it's out there, easy to find in Google.
And for the person that asked this question, if you just send me an email, I'm happy to help point you in the direction of where you can find the chart and how it's used. Our next question is in regards to Revlimid. What patients are best prescribed Revlimid, and how well does the treatment work?
Yeah, so it depends on the specific situation. So Revlimid works best in patients who have anemia with deletion 5q. So that's a small subset of patients, around 10%. It's actually quite active in that setting. So 2/3 of the patients will stop needing transfusions, and that can last for, on an average, around 2 years. If they don't have deletion 5q, the response rate becomes lower. It becomes only one quarter at 25%. And the response duration is shorter also, around 30 weeks, 32 weeks, which is around 8 months. So in patients who have deletion 5q, I definitely would use it. And those who don't have deletion 5q and have lower risk and anemia, I tend to think about the differential options, which are erythropoiesis stimulating agents, luspatercept, and lenalidomide.
Thank you. This question is in regards to luspatercept. They'd like to know, is luspatercept contraindicated in patients who have had a stroke 5 years before?
I think, again, like this question basically should be addressed based on the specific risks and benefits, because if a patient doesn't have any other option, sometimes you think about, okay, does it make sense to to take a medication, understanding that there could be additional risks, basically, in terms of whether it's a kidney function, whether it's cardiovascular. Because I think generally the main way we think that luspatercept could increase the risk is that if the patient hypertension becomes uncontrolled, if the patient hypertension is monitored and managed, then that might be reducing the risk, focus on making sure their cholesterol is good, making sure their cardiovascular risk profile is corrected. So it all depends on what are the different options and a risk-benefit discussion.
Thank you so much, Dr. Zeidan, for sharing your time and your expertise with all of us today. And if you'd like to watch this session again at a later time, it will be available on the conference platform in the next hour by accessing this session. Or you can also navigate and watch the session using the on-demand tab on the platform. If you have any additional questions, please send them to us in 3 ways. Send an email to help@aamds.org. Call our helpline at 800-747-2820, extension 2, or submit your question to our Facebook page. Please do take a few minutes to complete the session survey. It's important to us to have your input. It does help us with planning our future educational programming. The next session is our lunch program. This offers 2 options. First, you can join and listen to other patients tell their stories of hope, or you can join the chat sessions and chat with other patients. To join the chat sessions, open the community tab at the top of the conference homepage and select discussions. Next, you'll simply just select the group discussion that you would like to join. Please know that these discussion groups are not facilitated by a moderator. They're just meant to be open discussions between patients and families while you enjoy lunch. The lunch program will begin in approximately 15 minutes. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family as we've done for the past 38 years. This concludes our session.